For our last section on molecular testing and such, we have Dr. William Cance, surgical oncologist. He's a physician scientist, formerly American Cancer Society, and now at Grail. He's going to discuss multi-cancer detection systems. Thank you.
Thanks very much, and good morning. It's a pleasure to be here today to talk about the promise of multi-cancer early detection. This is going to be a paradigm shift in how we detect cancer early. My disclosures, I am with Grail, and I will be discussing Grail data today simply because they were the first out of the gate and have the most extensive publications, but I won't be making recommendations or anything like that. So this talk focuses on the unmet need for cancer screening. I'm going to talk about the need for a paradigm shift, why it's so important, what are these multi-cancer early detections, MCEDs as we'll call them, and how do they work? What are some of the clinical results to date, and what are key factors as we move forward in this space? So first of all, there's an enormous urgency to improve cancer outcomes. There's the demographic tidal wave. 10,000 baby boomers turn 65 every day. So we have demographics, worldwide cancer is increasing. We've seen from the COVID pandemic, it's brought more into focus, yet at the same time, we have fiscal pressures moving from volume to value. And we need to move from this break it, fix it, to let's prevent it, detect it, and intercept the cancer. That's the paradigm shift that we need. So when you think about cancers and about a screening program, you have to think, what are the risk factors? Who should be screened? When should we start? So we believe that age 50 is when we start, that you're 13 times more likely to get cancer over the age of 50 than before 50. The data there show that the age distribution of diagnoses and so forth that you can see between 55 and 70-ish. But older patients, the age is certainly one of the top risk factors. But here's the problem. The majority of cancer deaths in the United States have no screening mechanism. USPSTF, their A or B recommendations account for about 25% of cancer deaths. 75% have no screen. And that's where we need to make the shift from individual screening tests to screening individuals for cancer. So when you think about MCEDs, the intent is to reduce the late-stage cancers and have this shift towards stage 1 and 2. Here's the usual care. You can see about 6 out of every 10 diagnoses are stage 1 and 2. And as we've modeled this based on results, the results with MCEDs, we believe this can be shifted so that you'll get about 80% of cancers in stage 1 and 2 and fewer in stage 3 and 4. This stage shift is going to be a critical factor to show as the MCED tests move forward. And when you think about using these tests at a population scale, there's several considerations. You want low false positives, so you need high specificity. So you don't have to worry about people with a positive signal who you can't find a cancer. We want to limit the overdiagnosis. We want to preferentially detect cancers that are clinically significant. We get a lot of questions about this. It's like, oh, you're going to pick up cancers, these invasive cancers that are never going to do anything, never cause any harm. Well, that is not what we're seeing. These are the ones that we've seen as a general rule are very clinically significant cancers. And we'd like to be able to detect the cancer signal origin to determine where the cancer arose so you can focus your diagnostic workup. And as you expand these tests into populations, you want to look at very deep statistical analyses. You want to look at confounding conditions, comorbidities. How does that influence the test? You want to check independent tests, and you want to do it in people without known diagnoses. And of course, we need to see what these tests do in diverse populations. Does it work the same in all populations? And of course, the equity question. We need to make this a democratic test. At the same time, policy is very important, that we push forward for insurance coverage, Medicare coverage, and so forth. President Biden, when he talked about his moonshot, he prominently featured MCEDs. And there's actually a bill pending in Congress right now, the MultiCancer Coverage Act. We're hopeful it will get passed, even in the lame duck Congress. And you can see the lawmakers there who have been very supportive in driving this bill, and other advocacy groups have been in support as well. So stay tuned. That should hopefully get some action in the next few weeks. So we're seeing an expanding landscape of MCED tests. And how do they work? So we've talked a lot about circulating tumor DNA. We know tumors shed protein, DNA, and so forth. You can measure proteins. You can measure mutations. But most of these tests rely on methylation, the methylation sequencing. And this is looking at the epigenetics. So we're moving from the genetics and mutations, we're moving toward the epigenetics. So as you know, DNA gets methylated to turn it on. A methyl group, just that methyl group, can really turn on the genes, and cancers have a lot of methylation. See, that organic chemistry that we had to learn is coming back here to help us now, right, with methylation. So that's what's really active that measures the epigenetic changes. So deep methylation sequencing, we're using what's called bisulfite sequencing, is what a lot of these approaches focus on. These are some companies here, CancerSeq, with looking at both genes and proteins, PanSeer, 5 cancers with looking at methylation, Burning Rock and Grail both do deep methylation sequencing. So what are some of the early results from MCEDs? So CancerSeq detected 8 types of cancer, 62% sensitivity in stages 1 through 3 non-metastatic with a very high specificity. CancerSeq, which was Thrive, is now part of Exact. They'll be starting a trial next year, they said at that recent meeting, and will likely use PET-CT to determine the cancer signal origin. Delphi's reported a test with 7 cancers, 73% sensitivity and a high specificity, along with identifying the origin of the tissue origin. Burning Rock is based in China. Their clinical trials right now have been launched in China. They focus on a discrete set: liver, colorectal, esophagus, pancreas, lung, and ovary, and reported in their initial results 80% sensitivity, 98% specificity. Now, Grail's test was a serendipitous finding. This test started in Illumina. A scientist was looking at pregnant women, looking at cell-free DNA in pregnant women, looking for fetal DNA for genetic mutations rather than amniocentesis. And she found in several women that they had cancer mutations, and mutations that were associated with cancer. And she was told, nah, that can't be, that's not true. In fact, every one of those women had cancer. So this really started the process with multi-cancer detection. Grail spun out. The breakthrough device designation was achieved in 2019, and last year, about a year ago, a laboratory developed test was launched. None of these tests are completely FDA approved, none of them. So we're waiting for that. So I wanted to make sure to make that point that we still have ways to go before these tests can be FDA approved. So the Grail test is called Gallery. You'll hear it as Gallery. And it focuses on deep methylation sequencing that we talked about. And think about this. We sequence 1.5 million CPG islands in every sample. So it's very deep methylation sequence. And of course, that generates lots of data. So the bioinformatics and data science piece is critical. So to get this shared signal, we apply machine learning and artificial intelligence. And so that's how we can determine whether there is a shared signal, the common cancer signal, and where did it originate. So this classifier, the neat thing about these tests are that they keep getting better because you train the classifier based on your next level of data. So as we get tumors that were detected by MCEDs, tumors that were not, tumors that did not shed ctDNA, that data all gets fed in and in the featurization of the AI. So we can take a lot of different parameters, turn them into ones and zeros, and analyze this back. So it's a dual process. And I believe this is just the start for this deep sequencing, because there's also possibilities of predicting treatment sensitivity, et cetera. That's not what we're not anywhere near there at this point. So what about the clinical test? Grail has a robust set of clinical trials that are shown here. The foundational trial, CCGA and Pathfinder, I'm going to speak about in more detail. CCGA was published last year, and Pathfinder was just presented at the European Society of Medical Oncology meeting in September. The paper should be coming out. It's about to be submitted in the next few weeks. But you can see there's validation tests in women undergoing mammography, individuals with high risk of lung cancer. We're looking at real-world data and how is it implemented in other populations. We're using it to see if we can augment people who have symptoms of cancer. So altogether, we have over 335,000 participants in the trials. So significant numbers. But let me go back to CCGA and Pathfinder. So CCGA was a case control trial, about 15,000 participants. So it was people with cancer, known cancers, which you need to get the sensitivity, right? You have to know whether you have cancer or not. And then it was a control group. Pathfinder, a more recent study, was designed to look at the patient journey when you get a positive signal. What happens after that? How does that journey go, time-wise, success-wise, and so forth? So here are the key performance features from our first test, what we call the CCGA test. We detected over 50 types of cancers that are shown on the right there. And you can see there's a wide variety. There are a lot of cancers that that are very aggressive. We do not detect brain cancer. Doesn't cross the blood-brain barrier. The false positive rate was 0.5%. So out of every 1,000 tests that are done, 5 of them will be false positives. We were able to localize to determine the location of the cancer in 89%. And if you look at 12 pre-specified cancers that represent 2/3 of the cancer mortality, our sensitivity was 68%. I'm going to drill down on that a bit more here. Here are these 12 pre-specified cancers that I just mentioned. And this shows the sensitivity across stages 1 through 4. So you can get an idea of the lower stage and the higher stage. Now, as you can see, we do have a higher sensitivity in more stage 3 and 4 cancers, which you'd expect. They're probably shedding more ctDNA. But we are getting cancers in earlier stages. Look at pancreas, about 60% stage 1 and 2, liver bile duct, over 70%, and so forth. Head and neck has good sensitivity at earlier stages. The test is very sensitive in the GI system. That's one of the best areas for looking at the test. Again, what we want to try to do is to see this stage shift. It's very important for us to see that we can shift these stages with these tests. Now, Pathfinder is a much smaller study, the one that was just presented, and it was just designed to follow, to check the journey or to follow and understand the journey of a patient. Of the 6,600, there were 36 cancers and 35 participants. On the figures, you can see the solid tumors on the left and the hematologic malignancies on the right. The light colors show the standard cancer screens that we detected. We were complementary to those, additive to the numbers of cancers that were detected by the standard screens. And you can see the stage 1 and stage 2s, which are in triangles and squares. Within liquid tumors, lymphoma was the most common diagnosis. 12 of the 17 malignancies were lymphoma. The take-home here is about half of the patients had stage 1 and 2 disease. So we did see a stage shift to 1 and 2. And in 71%, there was no standard screening. So it gets back to that original problem of the cancers that don't have standard screens. Now, in this study, I want to talk about the positive predictive value. And the positive predictive value was 43%. So if you have a cancer signal detected, 43% percent of those people had cancer. And you may say, well, wow, that's 43, shouldn't it be 90, 95, which we'd like? But if you look at the other screens, what is their positive predictive value? Mammograms, 4%. Colorectal, even with the annual stool-based FIT screening, is about 9%. Lung cancer, about 9%. So there's always room for improvement, but the 43% positive predictive value, we're very, very pleased with at this point. Now, I'm just going to briefly mention the NHS Gallery Study before I take you through a couple of those cases from Pathfinder. This study completed enrollment of 140,000 participants. It completed enrollment in the spring. It's designed to demonstrate an absolute reduction in the numbers of stages 3 and 4 cancers. This was the fastest enrolling clinical trial in history. It was faster than the original polio trial. And it's a randomized trial where blood is drawn on these individuals in the United Kingdom in partnership with the National Health Service. Blood is drawn, half get the test, and half don't and have the blood stored. And then they go through the evaluations if cancer signal is detected. So this test is ongoing as time goes on. Keep your eyes open for this. This should really provide a lot of evidence about the stage shift that we believe we will see. So finally, here's 2 patients from Pathfinder, and here's their diagnostic journey. This is the way this works. You get your signal detected. In this case, it was colon and rectum was the 1 and 2 was the upper GI tract. We give 2 possibilities for cancer signal. So patient underwent CT scan. It was negative. Went to GI referral, had upper and lower endoscopy, negative. But they were persistent. They had endoscopic ultrasound, and on day 60, they found a duodenal cancer, which was stage T2 and 0. And here is the tumor in the 3rd and 4th duodenum. Here's a case, a patient's over 70, no history of cancers, a smoker, had a positive cancer signal, which was pancreas, gallbladder, secondary lung. And within 38 days, pancreatic cancer was diagnosed. You can see that by day 9, you're getting some positive results with the CA19-9. And then when you look at the CT scan, it's a lesion in the proximal to mid-body. There was a potential metastasis on PET, but it's a body of pancreas lesion. And it was biopsied, confirmed, resected, and it was a stage 2B T3N1. When have you seen a body of pancreas lesion present like this? Right? Usually they present, as you all know so as well, I've done a lot of pancreatic surgery in my day, but we usually see them when they are too obviously invading the nerves. So I believe that this patient has been helped locally. So local control, we have to keep thinking of local control while we await the results of survival. I can't tell you the survival is going to be improved. They're now about 500 days out from their treatment. But I believe cases like this show an immediate impact on local control when you can pick up these cancers. Outstanding issues, health equity and democratization. We're very committed to that. Everybody has a right to this test, no matter who you are, and we have to make sure that that happens. And as time goes on, as we get reimbursement, and that this test will be cheaper and will be able to be implemented in everybody, not just selected individuals. Sensitivity and specificity is an issue. Higher sensitivity, greater sensitivity is going to be a lower specificity. So you have more false positives potentially. So we have to keep tabs there of the false positive issue. The biology of ctDNA, it's just alluded to in our last presentation. Are tumors that produce more ctDNA bad actors? We published a paper last year in Annals of Oncology that did suggest that was the case, for, looking at tumors that didn't shed ctDNA, false negatives, compared to those that did. And there was a survival advantage across stages. Finally, endpoints for clinical trials. There's a suggestion by the NCI that they'll start a 10-year randomized prospective trial. And do we really need that? Do we need a 10-year trial? We'll see. We would argue that we will start seeing even more results, even that this is just the beginning, what I've shown. And this test is going to be evolving. This isn't the one and done. This isn't like, okay, we're done. We can just follow this. This isn't just like a new drug. This test evolves with the machine learning and the AI approaches I discovered. So we look forward to seeing the results of multiple tests as companies go forth, because even though they're in their infancy, we believe that multi-cancer early detection tests have the potential to dramatically reduce the cancer burden, probably more than we have seen in modern medicine. So thank you. I will stop there and answer questions.
One question, Dr. Kapoor.
So, my question is, on your curves, or on the graphs, why was the discrepancy in the bladder cancer? Everything else made sense. The bladder cancer did not make sense. Stage 2 in bladder cancer was lower than everything else. Did you look into that?
No, we don't understand that. We are looking into urine tests, urine ctDNA. Interestingly, we didn't, in melanoma and kidney, we didn't pick up stages 1, 2, or 3, but we picked up every MET. So is there, there's some immune things. We don't know yet, but that's a great question, and certainly with bladder, we're looking at other approaches.
Awesome. Thanks, Dr. Cance.